Okay, shall we go?
All good.
I welcome everybody to our afternoon webinar. This is the fourth in our series on various palliative care topics. Could everybody pop themselves on mute if that's okay, because we've got a bit of an echo from somewhere, or is it just me that can hear that?
There, I've muted them, it's fine.
Well done. So these are run by Cardiff University in conjunction with some of the specialist palliative care clinicians in the Cardiff area. So we'll just introduce ourselves. My name's Jo Hayes. I'm one of the palliative care consultants from the Marie Curie Hospice, which is in Penarth near Cardiff. And my clinical role is specialist palliative care community team. Our other speaker today is Catriona Seed, who's one of the clinical nurse specialists from the City Hospice community team, and also joining us for panel and discussion bits is Elaine McLeish, who's one of my colleagues with the Marie Curie community specialist palliative care team working in the Vale of Glamorgan. So we'd be really grateful if you are able to sort of come in when we're asking for discussions or thoughts, or put questions in the chat if you want to try and make it slightly more interactive, if that's okay. And before I hand over to Kat, I'm just going to ask who we've got on the call and ask Charlotte to run our polls, if that's okay. So I think the first poll is about your setting. What setting are you working in?
So you should all be able to see that now. So we've got 50% GP, 25% nurse and 25% palliative care. Great.
For some reason I can only see the polls in the chat, but yeah, that's okay. Thank you. And do you want to go on to the second poll, Charlotte, which is your role, current role, if that's okay? So whether you're working in community nursing homes, secondary care, mainly specialist palliative care, or a mixture.
So we've got 33% mainly community. Oh, let's move in. 50% mainly community, 25% secondary, and 25% specialist palliative care.
Hey, thank you very much. So I think I will hand over then to Kat to make a start on managing distress at the end of life. Kat's going to speak first, and then me later on, with hopefully a bit of chat in between. And Charlotte's helping us out from Cardiff University and running the session. So over to you, Kat.
Lovely, thank you very much, Jo. So hi everyone, my name is Catriona Seed. I'm one of the clinical nurse specialists at City Hospice, as Jo has said, and we're here to talk today about managing distress at the end of life. I wanted to start off with throwing the question out to people in the group. You know, does anyone have anything specific, any experiences they've had about the challenges of managing distress at the end of life? You know, please feel free. I don't think we've got a lot of people, so if you put your hand up or pop something in the chat. I know from my own experiences, a lot of the time it's not just the distress of the person, but it's the people around them. Elaine, did you have any thoughts about this? Or Jo?
Sorry, I've turned my mic off. Yeah, you're right, Catriona. It's mainly about the people around them as well, because it can be a very distressing symptom, not just for the patient, but for the family members as well, especially when they're caring for them, and especially in community as well, because there's long periods of the time when they're caring for family members on their own, so it can be very distressing.
Yeah.
And I would say one of the challenges is to know whether this is delirium because someone has something that could be reversible, like it's medicines related, or it's a urinary tract infection or something like that. I find it a challenge to know whether it's that you might be able to treat, or whether it's terminal agitation where you may be thinking more in terms of sedation. And that's, I find, even more difficult in the community because you haven't got people on hand the whole time to be continually monitoring or continually giving sort of small doses of sedation if needed, and you sometimes have to be a little bit more decisive because, you know, district nurses are amazing, but they are not able to sort of visit every few hours, really. So that's one of the challenges that I would find. So yeah, I don't know whether anybody else would like to comment. Please do, because otherwise we all end up talking to each other.
And to reiterate what Kat said, if you want to make a comment instead of typing it into the chat, just pop your hand up and we can unmute you and you can talk.
Okay. Shall I just continue, and as people have thoughts or any questions, then maybe we can sort of address it as we go along? Okay. So the overall aims of today is to understand how to manage distress in general at the end of life. And as Jo says, to try and understand perhaps how to identify the differences between distress, delirium and terminal agitation, because it's not difficult, it is difficult, and it's something that can be very challenging at times. We want to explore the challenges of supporting the dying person when they're in distress and the people important to them and how we can support them going forward, and to look at not just the pharmacological methodologies but also the non-pharmacological, and like we say, just pop your hand out or pop anything in the chat as we go along. So what is the difference? And it's really hard sometimes, isn't it? There's a lot of overlap across the three conditions, but obviously trying to identify what is happening and whether it is distress, delirium or terminal agitation will be really important, because it will change our management, and it will sometimes change what medications we're using and what support that we're getting for people. And it's really important when we're providing any end-of-life care that we really take that holistic approach and that person-centered approach when we're taking the history, when we're sitting there with patients and discussing things, and when we're planning how we're going to move forward. And especially when it comes to things like managing terminal agitation and how we're using the medications that are available to us, we need to be working together with the families and working together with the dying patient to make sure that they're comfortable with what we're doing. So that holistic approach is absolutely vital. It's worth noting as well that people with cognitive impairment are more likely to experience delirium or increased agitation at the end of life. And again, it's making sure that we're looking at those potential reversible causes for that. And as Elaine has said already, it's understandably very distressing for the people around the dying person. And it's really important that they get the support and they know what to do as things are developing. So first off, general distress. So I'd say most of our patients, when they're approaching the end of their life, suffer an element of distress when they're coming towards the end of their life. They're going to be worried about who they're leaving behind, whether it's loved ones, whether it's friends, you know, just leaving their life and leaving the people that they care about behind will cause distress. But we also need to look, as we were talking about that holistic approach, about the other situations that can cause distress. What is the social situation? Do they have enough care going into the house? Or are they not getting enough support? Perhaps it's a council house, and when they die, their loved ones are maybe not going to be put on the tenancy. That can cause a lot of distress. They may be worried about their loved ones when they die because they may be made homeless, and this is a reality for quite a lot of our patients. There will be financial concerns, you know, paying for the funeral, of paying for ongoing support for other members of the family, just all these little things, especially in the cost of living crisis at the moment, which doesn't look like it's going to improve anytime soon. These are going to be genuine concerns that can cause people extra distress. The problem is, if people are feeling distressed, if you think back to your total pain model that I believe James will have touched on a couple of webinars earlier, you know, if you will have increased pain and other symptoms, if you're struggling with financial or spiritual or social situations as well, it does impinge on the actual symptoms that you're living with. As I touched there, spiritual concerns. It's really heartbreaking. Some people who are strongly religious can sometimes lose their faith when they're approaching the end of life. Maybe they're beginning to doubt what's happening and the question, why me? Why is this happening to me? And that's really hard for people, especially you can have people that have been clean living all their lives and then they get a diagnosis of cancer and they think, well, why did I get it? And they're coming to the end of their life, well, what have I done wrong? And it's really hard for them sometimes to come to terms with that. It can cause a lot of psychological distress. It's also remembering looking at the family situation, thinking about, how old are the children that they're leaving behind? Are they still quite young? Are they children? Or are they teenagers or young adults? Being left by a parent. These things will have huge impacts on how they're managing distress at the end of their life. And all of these things need to be taken into consideration. Distress can also be caused by their current symptoms. And it's really understandable if we get people who maybe don't suffer pain or maybe don't suffer breathlessness, but they've heard that these are common symptoms that people suffer with at the end of life. And they can be genuinely frightened of developing these symptoms as they deteriorate. Now, as we know, not every single person develops these symptoms as they approach the end of life. But it's really important that we address those concerns and talk with people and give them that reassurance. And of course, the really crux of the matter is sometimes they may be struggling to accept that they're approaching the end of their life. For whatever reason, maybe they've deteriorated really quickly, maybe there's always been an element of denial, but actually having to sit down and actually face the fact that their mortality is not just coming, but it's staring them in the face. It's really difficult. Even the most pragmatic person, it's a difficult thing to face. And we need to acknowledge that and give people the support for this. Now, all of these are just those general distress that people can suffer. And obviously, this is very different than something like delirium. So delirium is specifically an acute change in cognition. It's often multifactorial. And it's often something that would normally be reversible, but that can be challenging at the end of life. So you can often have these either very hyperactive episodes or increased agitation, or these very hyperactive where they're almost unrousable for big periods of time. And often we see a mixture of the two. And we often see the challenges of fluctuating consciousness. And I think the most recognizable of the symptoms is when people start having hallucinations and delusions. And as I said before, this is particularly common in people with reduced cognition anyway. They are more likely to have these symptoms. But it's also, you will see this in people who don't have any cognitive impairment as well. And it's really important that we assess effectively to identify whether someone is actually delirious or whether someone is distressed or terminally agitated, because it will change our medication management. Delirium is very distressing for sometimes a dying person. They're not always aware. If the hallucinations aren't causing them distress, they may not be aware of what's happening, but the people around them can be very distressed by this, which is completely understandable. And we need to make sure that there's that support for them. And as I said, it's unlikely that we can potentially treat the underlying cause of delirium. But as Jo has already mentioned, we need to look at things like infections, like urine infections, like chest infections. Potentially constipation or pain can be common causes of delirium. So it doesn't mean that we shouldn't try to treat the underlying cause of delirium if it's appropriate. And sometimes it is just a case of we're just treating the symptoms, but it is something that we should always consider. And internal agitation. So it is agitation at the end of life, which is fairly obvious from the title. And it can be quite a sudden occurrence. We often see fluctuations in agitation. I know from my own personal experience, the extreme terminal agitation I often see is with the younger people in their 40s, 50s, 60s, often with younger families. And I often find, I think the phrase we often use is literally dying on their feet. We see common signs. You can see the list there. This isn't exhaustive. There are other signs as well, but generally you get this ongoing restlessness and confusion. You often get them vocalizing a lot, maybe calling out, particularly at night, which can be very difficult for caregivers because they're not getting any rest at night. We often find these people are hallucinating. And again, that's difficult because are they delirious or is it terminal agitation? And sometimes it's really difficult to know exactly differentiate between the two. They may start wandering and pacing. And as I said, this is what I particularly see in the younger people who suffer with terminal agitation. You know, they're often pacing around, unable to settle at all. And we often find this behaviour is much worse at night. And this is very, very common with confusion in general. It's often made worse at night. And part of that's because of the lower light levels as well. That can really impact how the brain is processing information. We will sometimes see aggressive behaviour as well. And that is so difficult for the loved ones to manage. I think, you know, delirium and terminal agitation is some of the most distressing symptoms that family members can watch their loved ones go through. And obviously for those people that either can't communicate or at this point are unable to, we do look for those non-verbal cues as well. So frowning and grimacing and fidgeting, especially for those that may be bedbound. So we won't necessarily see that much sort of expansive behaviour like the wandering and the pacing. But when we're seeing them in the bed and very unsettled and uncomfortable, then we need to be looking out for that as well. So what do we need to think about initially when we're seeing people with any of these behaviours? So we need to look at medications. We don't just need to rationalise medications where possible. I mean, if we believe someone's end of life, we should be doing that anyway. But we also need to look at whether there's been any new medications that have been added in that potentially could have caused these behaviours. We need to assess them to see if there's any symptoms that could be causing this problem. Is there an infection? Are they suffering with pain or with constipation? And it's really easy to underestimate the effect constipation can have on people. And I often find this in people with reduced cognition. When they are constipated, they can become extremely agitated, extremely distressed, and they often can't express it properly. And one of the things I'm really pushing, especially for carers providing care in nursing homes, is keeping an eye on bowel movements, because, you know, constipation is a really unpleasant symptom, and keeping on top of that is absolutely vital. Look and see if someone's suffering with fever. Again, that might be an indication of infection, but with certain cancers, you can also develop fevers as well. And obviously, if you've got a raging infection, like a raging fever, that can sometimes make you feel delirious as well. Looking for any potential emotional distress as well. And this is where taking that history from the family and having the caregivers present with you is really important when we're discussing these things, because there may be extra elements that we're not taking into account. There may have just been another recent bereavement in the family, which might be exacerbating the emotional distress. There could be something else going on that we're not aware of, that we need to take into consideration. And where possible, we should always be looking at trying to use non-pharmacological methods, if possible, before we start using medications. One of the reasons is that obviously if we can avoid using medications, great, but also there can be a lot of concern about overly sedating people at the end of life, and we often see these things rearing their heads up in the media. But actually, especially for those in terminal agitation who are often quite alert for big periods of the day, they're often keen to spend as long with their family as possible. So it's really important to sit down with people and have a plan about how we're going to manage this if we are going to go down the medication route. So I'm going to throw something back out to the group again. So what tools are people familiar with helping them to diagnose delirium and agitation in the community? Please feel free to put your hand up or put something in the chat, or Elaine and Joe, please add in as well. I think there's a couple of tools that are really quite helpful. I'm going to bring a slide in about one of them in a minute, but the nursing homes, they often use things like the Abbey Pain Scale, which is particularly useful for people who are non-verbal. And it's a way of more holistically assessing someone to identify not just if they're expressing pain, but potential agitation. And there's things like the 4AT, I want to call it. Did anyone have anything they wanted to add?
I guess it's. Oh, we're a bit echoey, aren't we? Common for, or not unusual for people not to be using a tool at all, really. And then you are reliant on how you find that particular person on the day that you talk to them, or what their family are telling you, in that they're usually okay all day, but as soon as we get towards the evening, they seem to get really, really agitated and muddled, and it's worse at night is often what you hear, isn't it? It's like sundowning, really. So yeah, lots of people aren't using tools at all, and I think one of the important points is that certainly hypoactive delirium, so people that are not wandering around and moving a lot, and are just quite sleepy and in bed, it's much harder to pick up the delirium then. And so using a tool like 4AT tool might alert you to it. So when we started screening everybody who came into the hospice for delirium, we picked up an awful lot more. So lots of people have got a bit of delirium without you quite knowing about it. I don't know if you want to just share your 4AT picture, Kat.
Let me just, I think I need to bounce out. Hold on. I've got it somewhere, hold on.
Sorry.
No, that's okay.
Just 4 simple questions that anyone would be able to ask as a screening
can you see it up?
tool. Yeah. So there we are.
This is the assessment. So there we go. So I'll try and scroll through it a bit slowly, but it's looking at 4 elements. Alertness. So are they normally alert, fully alert, but not agitated throughout the assessment? Have they got mild sleepiness for less than 10 seconds after waking, but then they appear normal? And then they score a 4 for clearly abnormal. So that's for someone who's markedly drowsy or agitated and hyperactive. And then seeing if they're orientated, so ask them to clarify their age, their date of birth, and where they are in the current year. And then if they're making either 1 or 2 more mistakes, that would score. And then you can see there's attention and acute change of fluctuating course. And so again, it's challenging someone to see if they can do the months of the year backwards. I think I would struggle with that on a busy day sometimes. But there you go. So, and then acute change or fluctuating course. And if someone's scoring 4 or above, then they would be identified as being possible delirium with or without a cognitive impairment.
And I know, Kat, you talked a little bit about the difference between cognitive impairment, which is a more chronic thing with patients with dementia, for example, and delirium, which is acute and fluctuating. Both can make you score on a tool like this, obviously.
And it's hard if someone's got cognitive impairment and delirium on top, and that's where knowing the person and getting a good history from the person is really helpful to identify that delirium on top of an acute, on top of their cognitive impairment. So, right, where were we? Hold on. Right. Are you seeing the slide again? Okay. Fab. So
I can still see the 4AT cat. I can't see the presentation.
Oh, hold on.
While Kat's changing her slides, does anyone want to ask us any questions? Put anything in the chat. Let us know their thoughts on anything.
Right, so let's try that again. Better?
Yeah, all good.
Fab. So there was another one I think is really helpful just because it's often the behaviours that we're seeing. It's actually pain assessment and advanced dementia, but actually when you look at it, you see these behaviours in people without cognitive impairment when they're agitated at the end of life. So it's a really nice tool just to be aware of. And again, it's scoring. So you've got the score down the side. If you score more than 4, then someone's obviously designated having pain. But I would also say that they've got an element of agitation as well. So it's looking at some of those non-verbal signs. So are they having laboured breathing? That can often be a sign of distress. Are they moaning or groaning or calling out? Looking at those facial expressions. Are they frowning? Are they looking distressed? Are they grimacing away? And looking at that body language. And particularly that description of the body language where they're rigid and their fists are clenched and they're all tucked up and they just look so tense. Sometimes I've walked into houses and someone's told me, oh no, they're really comfortable and relaxed. And I've looked at this person looking so tense and this tiny little ball. And actually this person's needed medication to help relax them. So this is something that's quite helpful to just have in the back of your mind as well. And there's an important distinction as well in this I like about the consolability. So for someone who's able to be reassured by voice or by touch, so that lovely non-pharmacological approach, compared to actually you cannot console them or distract them at all. And then, you know, that's the point where we're going to need medication to help manage their symptoms there. So looking at that non-pharmacological approach, it's really important to consider our environment. And one of the things that we need to be looking at is actually, you know, are there roadworks outside? And they've got a window open, it's really noisy and it might be contributing to someone's distress. Is the environment suitable for the person receiving that end-of-life care? There may be things that we cannot change, but is there anything that we can look at that we can maybe adapt to make the situation better for the dying person? It's really important that we consider those simple things like reassurance, like holding someone's hand and just talking to them gently. Maybe talking about good memories or telling them that other people that they care about are okay, or sharing the latest cricket scores because they always loved watching the cricket and things like that. And often music, putting their favourite music on, you know, nice and quiet so it's not too disruptive, can really make a difference to people. Something I used to do in the hospice I used to work at, Princess Alice down outside London, is things like aromatherapy. So you can get these lovely aroma stones or put a diffuser up and just have lovely, gentle smells can sometimes just relax someone, things like the lavenders and things like that, and just help people feel a bit more calm. And obviously, you know, things like make sure someone's not constipated or in urinary retention, and make sure that they're comfortable, really important. But the other thing to remember is how the people are around the dying person, because we are emotional sponges. And the reality is when you've got very distressed relatives caring for a dying person, you will often see that dying person, even if they're minimally responsive, they will pick up on that anxiety and that distress. And I have often seen it myself, where the family are so distressed and so anxious, you can actually watch that dying person become more agitated as those emotions get stronger and stronger. So we really need to make sure we're giving the people around them that support and make sure that they're coping and that they're accepting any support or any help that's around them. And then looking at the pharmacological management. There are 3 medications we typically use at end of life to manage distress or delirium. Or the first one, the standard one that we're familiar with, will be midazolam, and that is a general good medication used for management of anxiety. However, if we've got someone specifically identified as being delirious, we should be considering haloperidol and make sure that's available as a subcut injection in the house. And that can be given as a 2.5 milligram subcut up to 4 hourly. Obviously, if you've got someone with renal impairment, you'll probably have to reduce that dose. And the same with levomepromazine. Levomepromazine is a very useful medication that we commonly use for terminal agitation, particularly if it's not responsive to midazolam. So those patients that are pacing in particular, we find it really helpful for. And again, the standard dose would be 25, but in the community we often are careful because we're not there 24/7 to monitor for risks of falls or anything like that. We tend to go for 12.5 to 25 milligrams subcut. And again, if someone's got renal impairment, we may need to look at reducing that dose. Okay. We need to look again if they're delirious, if we can help their symptoms with things like antibiotics. So if they can still swallow medication safely, or if they can swallow the liquids and getting them liquid antibiotics to try and reduce that symptom. And then I won't go into too much detail because Jo is kindly going to go through this in a bit more detail, but we should be looking at the rest of the symptoms as well and just make sure they're well controlled to hopefully reduce any impact on their distress and any potential delirium. So we should be assessing their pain, we should be assessing their nausea and vomiting and using the medications as advised. And obviously, as I've touched upon with constipation, it's vital that, you know, we help people remain comfortable and they're opening their bowels. If they're not able to tolerate all laxatives anymore, we may need to think about suppositories or even enemas. And at end of life, we want to think really about microlax. It's a much smaller volume and it's usually much better tolerated, especially at end of life. So Jo will go into this in a lot more detail and talk about how we can use this in syringe drivers as well. And my last point really is the collaborative working we do in the community. None of us can do this job on our own. We are a huge team of very skilled professionals. Yourselves as GPs working alongside the district nurses, the specialist palliative care teams across Cardiff and the Vales, so that's City Hospice and Marie Curie. The care agencies, so the people going in and providing that personal care. And again, it's so important to make sure that caregivers are getting assistance with that at end of life. They need that extra support going in. So it really is a team effort between us all. Was there anything else anyone wanted to bring to this, or anything anyone wanted to ask?
Everyone's very quiet today, Kat.
I know. I know you'll touch on this in a minute as well, Jo, but as I hinted before, you know, especially when we're using things like levomepromazine for terminal agitation, it's really important that these discussions that are honest and open with people, and we really make sure that they understand why we're using these medications, and we're working together as a team with the family members and the dying person, and we respect their choices as well. As I said, a lot of families don't necessarily want their loved ones overly sedated at the end of life, and it can be difficult to manage that and to manage their distress as well. So sometimes there's a bit of compromise along the way, but it's really important to have those honest and open conversations with people about what we can do and what the impact that would be, so that they can make those decisions.
Agree. Do you want to add anything, Elaine?
No, I think it's just really important to do a full assessment as well, and looking at other things like, have they got a full bladder? Are they constipated? And just open discussions with the family as well. What do the family report back? Because very often we have families calling for a district nurse to come out and give an injection for agitation, and the patient's actually settled at that time. But there's other parts of the day where they, like overnight, they might have been unsettled and restless. And I think it's just really having an accurate assessment and thinking of the times when you're not actually seeing the patient as well.
That's a lovely point, Elaine, because it's so hard in the community, isn't it? It's so easy in the inpatient hospice or in the hospital. You know, they ring a bell, you can be there in a matter of minutes. If they're not showing the behaviour, I used to hide around the door and wait, and then the family would call me back. There we go, there's that behaviour, I'll go and get the medications. But, you know, the district nurses, no matter how quickly they can sometimes be half an hour. And then that time that behaviour may settle, district nurse walks away, 10 minutes later that behaviour's starting again. And that's really hard for family members sometimes, because it feels like they're not getting that help when they're then asking for it. So it's not easy, is it, to try and manage that?
No, and I think your assessment in the community is not just the assessment that you see for the time that you're there, it's the assessment for the last however long from the family as a proxy, isn't it? And you should be basing your treatment decisions on all of that.
Absolutely.
Yeah.
Thank you. Shall I will find my slides to share. Meantime, put your hand up, anyone, or put anything that you want to ask or comment on in the chat. Okay, can a Cat, it's you that I can see. Can you see my slides? Okay, so I can't see any of you lot at the moment. So someone will need to tell me if anyone's put their hand up or if you want to comment or anything, or just interrupt. Okay. So yeah, we've talked a little bit about terminal agitation, and we've talked a little bit about delirium, or sort of acute confusion, and Kat has also mentioned distress, suffering, anguish as a continuum of things really, and it's often hard to tell one from the other. So you know, the quote is just a bit of an illustration of what might be distress or suffering. How does one begin to describe a pain of 15 on a scale of 0 to 10? Which pain is it you want to know about? The pain in my belly, the pain in my soul, the pain in my family's face. In asking, I feel humbled, valued, acknowledged. And I won't go on and read all of the rest of that, but you can see for yourself. I'm sort of trying to get across the concept of not only total pain, but total distress, really. And there's often an awful lot going on with these patients and families in terms of physical, psychological, emotional, spiritual, social issues that we try to manage holistically as best we can. And how do we do that? So we have got teams of people. We've all got slightly different skills. Some of us are lucky enough to have either social workers who have a psychological support role and are skilled at that, or counsellors, or psychology, and even psychiatry. You know, for some patients will be important. As a team, so we might have spiritual care coordinators or people from particular religious communities that for some patients that's very important, so they may find helpful, and for others it's really not important at all, so what matters to that particular patient or their family. Kat mentioned complementary therapy, so photo there for someone doing some reflexology, so that can be really helpful in terms of anxiety management and relaxation. And you know, this nice smelling oil, a chance to lie down, play some nice music, have someone massage your feet. It's not going to take away all your problems, but it can temporarily just relieve some of the anxiety and help you to de-stress a little bit, even if it's for a short period of time. And some of our services run that service for families and carers and those who are close to the person who you are managing as well. Okay, you know, frustration for those of us who don't have good access to proper psychological support or psychology or mental health services. And I guess we all just try to do the best that we can with the services that we've got available. But it's not always the right thing to, give some more morphine, for example, to somebody who is distressed or anguished and not necessarily only got physical pain. Hope that's making sense. By all means, interrupt. If not, Kat, can only see you. So I'm just going to quickly talk a little bit about our patient. I know there's a lot of information here, but 70-year-old man, COPD, ischemic heart disease, diabetes, cancer, so non-small cell lung cancer, not amenable to surgery, treated with palliative chemotherapy. This is an older slide. I'd probably substitute 2021, 2022 or something in there. Disease has progressed, chemotherapy has stopped. He's been into hospital with what sounds like a chest infection, didn't improve on IV antibiotics and has come out at his request, really. This would be the sort of person that's come out on with, continuing healthcare fast track 1 or maybe 2 care in place, now finding it difficult to take his medicines, and overnight's been very agitated, had a fall. Family have called an ambulance. District nurses have also been out and given several doses of midazolam. Wife's very distressed. He's very distressed. He's quite hypoxic. And there are some of the medicines that he is on. So just have a little think about how you might approach him, and anything that comes to you, by all means, put it in the chat. I won't spend lots of time having a break because we probably need to move on a little bit. But how are you going to assess him? You're going to assess him face-to-face, virtually, telephone, proxy, by speaking to his wife. I would suggest that he needs to be seen face-to-face for you actually to get a good idea of what's going on, to be able to do a whole assessment of him and his family, to be able to do things like check whether he's got a full bladder and that sort of thing. I realise that it's difficult to get around to see everybody, and certainly if you're a GP or a district nurse, you're often trying to do things over the phone, and we all do that, and it's a good substitute for some circumstances, but it is not the same as seeing people face to face. How do you know what's going on here? Placing the situation in a longer context means, was he zipping around Tesco 2 days ago and is now suddenly completely different? And from the scenario that I've given you, that's not really the case. We know he's got progressive cancer. We know he's been in hospital and not responded to IV antibiotics and has come out of hospital with an expectation of quite a poor prognosis. And that would perhaps help us to decide what's actually going on here. Is there anything potentially reversible? Well, I'm not sure what. The cancer's not reversible. He's had IV antibiotics in hospital and not really responded. There could be something like a high calcium, for example, that if you did urgent blood tests, you might find. On the other hand, you have to wonder whether it's appropriate to be doing blood tests and where you're at in this gentleman's sort of disease journey. What do we know about what he would want for future? If he's just been discharged from hospital with an expectation of poor prognosis, it's likely that they will have had discussions about whether he comes back in, and he may well have said that he wouldn't wish that to happen unless there was a realistic chance of benefiting from acute hospital care. And it goes without saying really that we need to be sensitive in terms of our communication around the situation. So you've probably seen this slide before, but remember, this is a suggestion of the way that some people die depending on what's wrong with them. So the upright axis of the graph there is how well they're functioning. So the people on this call, you would like to think are high functioning, although it depends how much cake I've been given and what stage of the week it's at. And then on the bottom of the graph there, it goes over time. So for cancer patients, they often function pretty well for quite a long period of time and then decline in an almost linear sort of way. That doesn't always happen, but with cancer it sometimes sort of happens that way, and things like lung cancer with poor prognosis, it can happen that way. Whereas your heart failure COPD patients also tend to decline slowly over time, but they have these big dips where they've got like an infective exacerbation of their COPD or an episode of decompensated heart failure, for example. So it's harder for these patients to decide which episode is going to be the end of their life. And dementia frailty patients, the sort of people that might be in nursing homes, often don't function particularly well, and quite low function and sort of bounce along the bottom there. And it's again quite hard to tell exactly when things are coming to the end. So pragmatic approach there. If you're deteriorating month by month, then prognosis is likely to be in months. If you're worse each week, it may be that we're looking at weeks. If you're worse each day, it may be that we're looking at days. And I very often use that with people. And you can sometimes get patients or their families to tell you that themselves. Well, how did you compare to last week? Oh, I'm completely different to last week. I don't think it's going to be long, doc. The sort of thing that some people will say to me. Okay, so back to our gentleman. So I think potentially dying. This is potentially terminal agitation because we've thought about things in a longer context. We've thought about what we know about him, that he's got lung cancer, it's progressive, he's gradually deteriorating, he's been in, the IV antibiotics haven't made any difference, and he will have had his calcium and things checked in hospital as well. So we're probably managing the end of life care for somebody here. What sort of things do we want to consider? So we need to have medicines available for things like pain, breathlessness, agitation and delirium, which is what we've been talking about on this call, nausea, vomiting, increased respiratory secretions. Depending on where you work, people use slightly different things to address all of these things. Yeah, there's Buscopan in the picture there, that when I was working in North Wales, sometimes we certainly used lots of Buscopan for respiratory secretions, whereas in Cardiff we would tend to use either hyoscine hydrobromides or glycopyrronium. All of these things need to be got. So you need a prescription, somebody to find them in a chemist, somebody to collect them, someone to bring them back to the house, and somebody to write it all up on a community drug chart. And if you're a district nurse and you manage the sort of bingo of getting all those things ticked, then you might actually be able to give some of these medicines to patients when they need them. But it's a complicated process. So pain, common in people dying from any cause, not just cancer. Pain is just as common people dying from other causes like COPD or heart failure. We've talked about checking for easily fixable causes. You probably need a subcutaneous route because people who are dying often can't swallow or will stop swallowing effectively at some point and become much less rousable and perhaps semi-conscious and be at risk of aspirating. So you need a reliable route to give them medicines. And we often use subcut route because then you don't need a line in. We're often managing people at home, and putting in IV cannulas is quite burdensome and not very nice for them. And IV medicines really don't last very long because it's straight into your bloodstream. So with a subcutaneous route, you don't need a line and the medicines will last for quite a lot longer. People who need frequent subcut injections for pain, for agitation, or for anything else, you would think about putting up a syringe driver then, which is a continuous subcutaneous infusion and then doesn't need for the medicines to wear off and people to get pain back or become distressed again before they get their second injection. And also sort of stops the need for perhaps waiting for your district nurses who will be quite short-staffed during the night, and allows people to have more of a constant level of medicine. People on patches, we would tend to leave the patch on. Don't try to convert all of the medicine that's in it into a syringe driver. Leave it on as background, and you can add extra medicines in a syringe driver if needed. And you need to remember to change the patches when they are due to be changed. Which is something that I saw somebody in the acute hospital yesterday where they hadn't done that, and I think that had probably caused an escalation in the pain. So how do you put things in a syringe driver? How do you decide the doses? So just very quickly, for morphine or for oxycodone. So oxycodone, things like long tech and short tech, strong opioid that we often use as a alternative to morphine. You add up the total daily dose and then divide by 2. And that's the equivalent of your long acting. You might want to increase that dose a bit if that person is having lots of extras or lots of breakthroughs, but we wouldn't necessarily add in every single breakthrough. It depends a little bit on the situation. So for example, someone who's on MST or Zomorph 20 milligrams twice a day, The total daily dose is 40 milligrams, and then you divide by 2 for your total daily dose subcutaneously. So subcutaneously, the equivalent dose is slightly less in injection form because it's straight into your system. So the equivalent dose would be 20 milligrams per 24 hours in a syringe driver. And again, if they've had lots of extras or lots of breakthroughs, you might put the dose up a little bit. But what you wouldn't do is start a syringe driver on 10 milligrams over 24 hours, because what you're doing then is giving that person less analgesia and may cause recurrent pain or more distress. So much more important than remembering the calculations is to remember how to get hold of your palliative care team and where you can find them for help or advice. So I don't expect people to remember this stuff. I expect people to know where to look it up or know who they can contact to ask for help. That's much safer. So breathlessness, also common. Might sometimes be appropriate to treat specific causes of breathlessness, but this gentleman's dying. The avoid fans in COVID is very old, so don't worry. We're not worrying about fans and COVID anymore, and that was disproven at some point during the pandemic anyway, wasn't it? So non-drug measures are quite good for breathlessness. So open the windows, reassure people. You can use fans, and sometimes handheld fans can be helpful. Opioids are really good for breathlessness. Small doses of morphine, often smaller doses than you might need for pain control. Things like midazolam are good if there's lots of anxiety and panic with the breathlessness, which there often is. If you imagine how you would feel if you can't get your breath, you're bound to feel anxious and panicky. And then that drives the feeling of panic and breathlessness, and you get into a vicious cycle. So oxygen's only likely to be helpful if you've got low oxygen saturations, and even then it's a barrier really. You have to go through all of the hassle of getting it and having a load of oxygen lead trailing around the house. And we're not really interested in the numbers on oxygen saturations, we're interested in symptoms. So if people can look comfortable or can be comforted with non-drug measures or some medicines, then we probably go for that before oxygen. But sometimes if people are very hypoxic, oxygen can be useful. If they've got something like COPD, you have to be careful about too much oxygen. And what we often also get told from the community is that GPs, district nurses can't order oxygen, and it has to come from secondary care, which isn't the case for palliative oxygen. And it can also always be ordered from general practice for palliative purposes if needed. Okay. So restlessness, terminal agitation. I mean, I won't dwell because Kat has done this, but yeah, delirium, you might want to look for reversible causes or check for urinary retention and things. There's often a balance, as we've mentioned, between alertness and comfort. So I sometimes have conversations with families as saying things like, yes, the medicines may make them more sleepy, but actually from what you're telling me, they haven't got sort of time awake that's comfortable or pleasant or useful for them. They're either sleepy or they're awake and agitated and distressed. And so we have to strike a balance here between what would be the most comfortable for them. And if we're honest, what's also, less distressing for their family as well. So midazolam and levomipramazine we've talked about, and that's an example of how I might write them up on a community drug chart. Sorry about my rubbish writing. Nausea and vomiting. So if it has not been a problem before people are dying, then it may not be an issue when they're dying. It depends on the cause. I don't always automatically put antiemetics in syringe drivers. If somebody has been on morphine, for example, at a reasonable dose, when nausea is not a problem, then they won't necessarily feel sick if you just give them morphine in a different way. On the other hand, if they've never had strong opioids and you're starting them on morphine or something in a syringe driver, they may feel sick and you might want to add an antiemetic just in case. So cyclizine, metoclopramide, levomipramazine are some of the common anti-sickness medicines that we would use subcutaneously, and the suggested doses there. With levomipramazine, we would tend to use smaller doses if it's for sickness compared to if it's for agitation. Otherwise, it can oversedate people when you're just using it for nausea. Okay, and increased respiratory secretions or death rattle, if you like. Quite common, can be really distressing for family and can be a really unpleasant noise to listen to. But the people themselves, the patients who actually have increased respiratory secretions and rattly breathing, often look very, very comfortable and unresponsive, and like it's not actually bothering them particularly much at all. And that can sometimes be reassuring to family to explain that, well, actually, they look really comfortable. I know it's not very nice to listen to. I sometimes describe it as like drinking from a straw in a glass, where you get to the bottom and it makes a horrendous noise as you sort of suck up the last little bit of fluid. But actually, there's hardly any fluid there. It's just in a strategic place at the back of your throat where it's sort of rattling a bit. So non-drug measures can often be really helpful for respiratory secretion. So sitting people more upright or more on their side can be really helpful. And then, you know, we give one or other of these medicines, really depending on what we've got available and what the sort of side effects profiles of them all are. They're not particularly effective, but can be effective, I think, if you get in there early. So hyoscine hydrobromide is an example of what we might use for respiratory secretions. It's quite important not to use things like hyoscine hydrobromide if you don't think someone is dying. If they're a little bit chesty or a little bit breathless, or their breathing's a little bit rattly, you should really be assessing them first and having someone listen to their chest and decide, is this a chest infection that I should be considering antibiotics for, rather than just rushing in and giving them hyoscine because they've got their anticipatory medicines and they're in the house. Because to do that to somebody who's not dying, hyoscine's quite sedative. If people have it, they can sometimes then look like they're dying. Then if somebody comes along and says, well, they look like they're dying because they've had hyoscine, and you put a syringe driver up, it can all be a bit self-fulfilling, really. So yeah, we sometimes use glycopronium, which isn't sedative, and so there's less issues with sedation there. Okay. Where are you going to get your medicines? Chemist, GP surgery. GP surgery wouldn't be an option where we are in Cardiff, but is in rural North and West Wales, where they've got dispensing GP practices. The hospital, that's all a bit controversial, but the hospital should, in Cardiff, is able to be a backup, and I don't know how common that is elsewhere, but you need to find out wherever it is you're working as to how you get medicines urgently. Okay, lots of people have got schemes available within their health board. In Cardiff, we've got designated palliative care chemists that carry a certain stock of medicines, and I'll show you an example of the stock list in a minute. But they tend to be chemists that are open longer hours and that you can park outside, and those of us working in palliative care all know where they are, but we all need to remember to tell patients and families, go to one of the designated chemists. Otherwise, what can happen is they will go to a chemist that hasn't got the medicines, they'll take the prescription off them, and then you're stuck, really. Okay, so I've just talked about that, really. Remember that someone's going to need to go to the chemist, and that is tricky if there's one person with somebody who's dying. You would hope that most people have got a friend, a neighbour, a relative that can do some of the running around for them. But we unfortunately don't have a sort of service like they would in Gwent, for example, or in Iron Bevan, where someone will deliver the medicines for them. Okay, so that's what we have in Cardiff and Vale Health Board, and that's our lists of chemists. And that's a list of the medicines that they would hold. So you need to all know what your local arrangements are. Okay, so back to our patient. Probably dying. What are we going to do with his medicines? So the Zomorph, probably going to put that in a syringe driver. Haloperidol, depends what it's for. It may have been for a bit of agitation or confusion. It may be for nausea. We might put that in the syringe driver, or we might put an alternative anti-sickness medicine in there. Or if we were adding something like midazolam, we might well leave the haloperidol out. Laxido, he really doesn't sound like he's going to be able to take very much orally at all to me, with the scenario that I've given you. And so unless he has severe constipation or impaction, we're probably going to not worry about his bowels too much in the immediate term. Aspirin, stop. Statin, stop. The whole world are on a statin, I think, and towards the end of your life, it's not helpful. Bisoprolol, depends why he's taking it. If it's for AF and controlling his rate and he can swallow something, you might want to prioritise that medicine. If it's for blood pressure, you wouldn't worry about it. Steroids, stop if he's clearly dying or can't swallow. If it was someone on a big dose of steroids who had maybe a brain tumour or something, lots of headaches, at risk of seizures, very sick from raised intracranial pressure, then that's the sort of person that I might try and give them steroids via an alternative route, so maybe subcutaneously. So insulin, he's type 2 diabetic. You probably wouldn't stop insulin in a type 1 diabetic unless we're talking hours or very short number of days for certain. But with type 2 diabetics, and that's not a big dose of insulin, then you can probably stop. Higher blood sugars are not dangerous, whereas having hypos is. So probably leave the insulin there. Okay. So this is the sort of thing we might consider for this gentleman in a syringe driver. So morphine, and we've increased the dose a little bit there in case pain is an issue. So the benefit of the doubt for somebody who's very agitated and maybe in pain, a reasonable dose of midazolam, and there's a reasonable dose of levomepromazine there as well. Some people might think those are quite big doses. It does depend on your setting. And I think in the community, we probably do tend to consider slightly higher doses of sedation because there isn't a nurse around the corner where you can just press the buzzer and they come running. But it's all individualized prescribing and according to the situation that you are in. And you need to remember to have all of your as needed medicines written up and in the appropriate doses. So breakthrough doses are probably about 1/6 of the total daily dose for things like opioids and painkillers. And midazolam as well. As you slightly go up in your syringe drive with midazolam, you probably go up with your breakthrough dose as well and not leave it at something like 2.5. Okay, and as I said, know where to find your local services and call for advice either in hours or out of hours. So where Kat and I work, Cardiff and the Vale, there's a separate community service, one for Cardiff and one for the Vale. The 7-day community specialist palliative care nurses work and are available via 111 7 days a week, so Saturdays, Sundays, Christmas Day, bank holidays, and there is 24/7 doctor advice via Cardiff and Vale switchboard for any healthcare professionals that need help with palliative care. Sorry, that's been a bit of a whistle-stop tour. I think I will stop talking there and stop sharing my slides, if that's okay. And what I'm going to do is ask Kat or Elaine what they would like to add, really, or if they have any comments, whilst everyone else has a think about whether they want to ask us any questions.
Yeah, just thinking about the prescribing at end of life care, it's really important to have the drugs in the house and them to be written up properly as well. Because sometimes if the frequency is not right, say it's 4 early and we could be given 2 early, then obviously the district nurses can't give the drugs. So it's just really important to make sure we've got the availability of them and that they're prescribed properly as well. Because the last thing you want is for families to be running around with drug charts and looking for medication as well when somebody's at end of life.
And I think so. What you and I, Elaine and Kat, would do if we see somebody in the community who hasn't got drugs and needs them urgently, is whilst we're requesting prescriptions, would also potentially phone chemists and check what they have got, so people are not trading around from pharmacy to pharmacy. And I guess we're lucky in Cardiff in that we can access secondary care for medicines if we need to.
Yeah, that's right. Especially on a weekend, we tend to know what pharmacies that stock the best drugs, that have the drugs, but we will do the ringing around for them as well, so that the families don't have to go around different pharmacies.
And as I said, those people who are lucky enough to work in an hour in Bevan, I think they've got a delivery service. So yeah, you need to, those of you who are on the call, if you don't know what happens in your health board, you probably should find out before it gets to 5 to 5 on a Friday, and you need to sort it out. So I don't know if you want to add
just want to say with the
sorry, go on.
I was going to say with Elaine's comment there about making sure that we're prescribing those medications correctly on the drug chart, I had an absolutely perfect example this week of some sudden deterioration identified very well by the GP that they're approaching the end of life. They'd had some medications given overnight by the out-of-hours GP, and all they had was a handful of vials in the house. They've gone out, they've prescribed the drug chart and put everything for hourly, and the poor district nurse is calling me. It was a brand new referral, so we'd not met them yet. So we're literally diving out to try and see this person. This poor district nurse is then running around trying to get the frequency changed and get scripts, because what the poor GP hadn't realised was, oh, there's medications in. There was only a handful of vials of everything and not enough to actually manage someone's symptoms going forward. And of course, it was causing more distress to everyone involved. And luckily, you know, we got it all sorted out, but it was just that extra work and that extra stress that potentially needn't have happened if it had just been identified first in the morning when the drug chart was written up. So it is making sure that we do that. And if you're not familiar, contact your palliative team, but also don't forget the care decisions, the All Wales Guidance care decisions for the last days of life, because it has got that symptom guidance chart in it as well, which has really clearly, really easy to follow guidance as to what medications we use generally. And obviously that's not patient specific, but you can then get further advice. But it does give advice about the standard medications, the doses and the frequencies. And I just want to bring a point to the sugars as well, if someone's on insulin, because in the care decisions there is an algorithm to help support people at end of life who are on insulin. And sometimes, not always, but if someone's on insulin but they are type 2 diabetic, they still may need to have a look at that algorithm. It's available there. It's really clearly written out, and what people would normally do is check the blood sugar once a day, and we're just checking for that blood sugar to sit between 88 to 20 millimoles. And what we're aiming for, as Jo said, is to prevent hypos. We leave it nice and loose. We're just trying to prevent severe high blood sugars. And again, it's all about symptom management. But that guidance, if you're ever unsure about managing and supporting someone at end of life with diabetes, again, the Care Decisions has a really good algorithm to follow through and get advice from. And if you need further advice, either the diabetic team or the palliative team would be able to support you with that as well.
I'm just trying to find the link for the Care Decisions Guide. We have put it in previous webinars, so that's where it is if anyone's looking for it. But if the two of you want to continue the chat, I will find it and put it in our chat here for people.
So I've usually got quick access to it. I think it might, oh, hold on, I might even have it on my computer.
Yeah, it's actually quite a good chart.
Yeah.
I will put it in now.
Hold on. Have you got it?
Yeah. So have a look at particularly at the symptom control guide that's at the back, which is really helpful. Okay. Fine. Does anyone want to ask us anything? Go on. So we get lots of time to speak to each other, don't we?
Yeah. It's really interesting seeing just how much overlap there is when you were talking through yourself, Jo, about supporting, so for example, that lovely case study you had there. I mean, with someone with a low oxygen level, that can sometimes cause delirious behaviour, can't it? But actually looking at how you're looking at the whole picture and looking at how that person's presented, the fact they've had that recent infection, the fact that they have deteriorated so suddenly since they've come home, to help guide your management. And it is that total holistic approach, isn't it, that helps then guide that management at the end of life. But it is such a challenging thing to help support people with.
Yeah, it's probably worth saying while we're on the oxygen subject that there's really poor correlation between oxygen saturations and breathlessness. Like if I made people run up and down the hill that's outside the hospice here, they'd be breathless, but they wouldn't be hypoxic, so they don't, it doesn't always correlate, and therefore giving people oxygen is, let's face it, it's a hassle in the community, and it's a hassle for patients and families, and it often doesn't make that much of a difference. For some people it's really important. So people with pulmonary fibrosis, for example, who've got really low oxygen saturations, then it can be really helpful. But they've often been sort of assessed in detail, haven't they, through the oxygen.
Yeah.
And the same with patients with COPD, where it's obviously important to set the oxygen at a specific level and not to give them too much. But we wouldn't necessarily go straight to oxygen for someone who's breathless from a lung cancer, for example.
I've managed to find the diabetic symptom control guidance. So you can see it's a really nice, colourful form. So generally diet controlled or metformin treated diabetes, we stop any management, we stop any monitoring, and that's fine. It's just as we start looking at some of the more modern tablets, and if someone's type 2 diabetes, put on insulin. But you can see it gives really clear guidance as to what we're doing. And if we're looking after people in the community, we're not going to be doing urinalyses. We are just going to be checking that blood sugar once a day, keeping those tests to a minimum, and just keeping that blood sugar between 8 to 20. And it gives really good, clear guidance into how much insulin that we need to use. And we won't always need to follow this specifically. You may need to adapt it depending on the person. And that's where sometimes getting advice from the diabetic team is really helpful. But there is that algorithm there, and that is just part of the care decisions, which is on the NHS Executive website.
Right, that's on the link that I've just posted in the chat. Okay.
Lovely.
It's all